I'm Dr. Demetrio J. Aguila III. I'm a peripheral nerve surgeon, I'm an ear, nose, and throat surgeon, and I'm also a plastic surgeon. I'm the host and founder of the Direct Care Movement podcast, where we dive into the intricacies of direct care, whether it's direct primary care or direct surgical care. You can find out more about what this movement is and where it's going and where it came from. I'm very excited to have with us today our guest, Dr. Brent Holmquist, who's a direct primary care doctor here in the Omaha area.
Pleasure. Thanks for having me.
Awesome. So, Dr. Holmquist, why don't you tell us a little bit about yourself?
Yeah, I'd love to. So I am a family medicine doctor. I've been out of residency since 2011, so about 13 years. I absolutely love primary care. I love the ability to see all ages, all sorts of different issues, both physical and mental, sometimes spiritual. And so that has always been my passion, my love. So I was within a fee for service model, insurance model for about 10, 11 years or so. And I decided to do my own thing. I started my own direct primary care practice, which is called Life Medicine DPC here in Omaha. It was a long time coming. I had thought about it. I had talked to some of my partners over the years about this. Some of them had been thinking about it as well, and just hard to pull the trigger, right? So it was always something in the back of my mind, probably since 2015 or so, when I first kind of heard about the direct primary care. And at that point, I was I couldn't really quite figure it out. It was just so different from what we were used to, and so yeah, it was always there, but it was hard to kind of take that next step, that leap of faith, until about 2020 during the pandemic. We decided, what? This is as good of a time as any, and started putting things together, and we can kind of talk about kind of that process of starting up your own business and so forth. But I certainly had some mentors, some people who kind of helped along the way, some different groups that were, even if they didn't know they were helping us, they still helped us along the way. So it was a great, or has been a great experience, and still is. So that's kind of the beginnings of how it started.
Sure. So now it's been my experience with direct primary care that most of the people these days that are going into direct primary care were in a conventional practice before making a transition. I don't think I've run across anybody yet who went into direct primary care right out of residency or right out of fellowship. Right. And when I talk to most of those people, they talk about the frustrations they had with the conventional model, and that's what ultimately drove their switch. Tell us about that transition for you.
Right. So, yeah, I think most physicians in the fee-for-service model and with using insurance end up having this frustration. I think we all share that as you build your practice, as you get busier and busier. And I think this goes for any of the systems out there, whether it's here locally or anywhere else, or small town versus large metropolitan area. There's pretty similar things that are expected of a primary care doc in regards to how many patients you're wanting to be seen, the time constraints that you have. The difficulty with your schedule, not being able to put people in for longer visits or shorter visits or stuff like that, and that to me was kind of the frustrating part, where the system was asking of us to do more and more with kind of less and less, meaning really more or less time. Seeing a person who has 10 different things on their problem list, and they want to address them all in a particular visit in 15, maybe 20 minutes. that ain't happening, right? That is really, really, really difficult. And if you even try to do that, you're going to fail. You're going to have problems with, misdiagnosis, or, you just don't get the history that you really should. So having to do more with less, particularly as the pandemic went on, that was, to me, kind of the, I don't say last straw, but that was the thing that kind of gave me the little bit of a push to, say, let's kind of look into it a little bit more seriously, and start at least building my business first, and then figuring out along the way, okay, is this going to be feasible? And it was, and it has been.
That's awesome.
Yeah.
So what do you think the main driver of those frustrations was? I mean, you kind of talked about, there's so much stuff we have to do in so little time, but what are the pressures, or what are the influences that lead to this model where you don't have time? Right.
So I think from a bigger business perspective, in these big systems, obviously you have to have volume. You have to have the numbers of patients that they want to see. In those systems, you've got obviously several layers above you that have to be supported as well. So at the bottom where I was, I am the one who is billing and collecting that money. And that is not only supporting my position, but also many layers above me. So what we found is that over the years, when the systems kind of merge and get bigger and bigger and bigger, it's just a bigger animal. And the more that the people at the bottom have to support, and so that, I think, has been a significant factor in how they want us to see so many, and I've done some of the just real brief analyses of kind of what it looks like as far as how many patients you needed to see, and obviously the systems do this on their own, but just for my own edification, I was billing I don't know, $1.5 million, and seeing probably a seventh of that, and obviously doing my own business here, all my gross income is not my net income. I get that. There's overhead, there's expenses, there's people that you have to pay. But with such large systems, and the amount that insurance companies either pay or don't pay into that, really kind of puts the financial squeeze on that system, and that squeeze is then kind of funneled downward.
Sure. So if you had to guess, when you were working in a conventional model, you mentioned there's multiple layers, multiple people involved in that one patient interaction, either directly or indirectly. If you had to guess, how many people would you guess that would be?
At least if for a primary care visit, for that interaction,
all the way up to the top, mind you, including the CEO and so forth and so on, all the biller, the coder, whoever else.
Boy,
just a rough guess.
I don't know. It's 10, at least 10, 15.
Sure.
Something like that. Yeah.
So your revenue had to feed 15, 16, 17 people.
Something like that. Yeah.
That's not including your family, of course.
Right,
That's, 15 or 16 incomes, right?
Right.
How about today in your direct primary care practice?
Just the one. Yeah, it's just me, and actually my wife as well. She is part of our clinic as well. She's an RN, and has helped out with the kind of office management and just everything that goes into seeing patients day to day. But obviously for us it's all together. So
sure. So then, one of the criticisms that I often get, that I'm sure you've heard lots of times, is, well, that's great if you're taking care of a bunch of rich people, you can't do this for the average Joe.
Right.
How do you answer that?
I think that's kind of ignorance, I would say. Certainly there are folks who have the means to pay however much they want to pay, and don't really care about how much they pay. That's a very small percentage. The vast majority of these folks that are in my clinic and who utilize our services, the vast majority of them are middle class. They're not rich. They don't have money coming out of their pockets, but they see the value in what we're doing, and particularly the value for them for their interactions with the clinic. They've had most of them have had problems with getting into the normal system, waiting 6+ weeks for a simple visit, or once they're getting in, or once they are in, and spending an hour, 2 hours, 3 hours at the clinic, and only a small portion of that is dedicated to the actual interaction with me. That I think frustrates a lot of folks. They're really wanting that personal interaction, just talking. And so I think for those people, they see the value of, okay, if I am personally seeing fewer numbers of patients, well, that means therefore they are being seen for longer periods of time, typically. Obviously, if they need a short visit, they can say, hey, I got a hard stop here. But the vast majority of my visits now are at least an hour. Even the acute visits, if they want them, they're usually there for an hour or so. And all of that hour is spent either you're just getting to know them, or talking about all the medical issues that they need to be addressed. So yeah, not everyone is rich. Not everyone has the means. I even have some patients that I've had to give them kind of special rates where I can cut the rate down to $10 or $20 a month because they couldn't afford it, and doing that for a couple of months, and they say, you know what, I can start paying the normal fee. Put me back at the normal fee at this point. So that's a really cool thing about owning your own business and clinic, is that I can make those decisions on my own without having to consult anyone above me, because
Sure.
it's all me.
Sure. So then help us understand how that math works out. So you talked about how you've made this more affordable for the average patient compared to a conventional model. Right. And you're seeing fewer patients and you're spending more time with them. Well, doesn't that effectively make you work for free? I mean, how do you keep the lights on? How do you feed your family that way?
Obviously, you're not doing it for free. That's silly. But no, I mean, so direct primary care. The vast majority of us do a time-based reoccurring fee. So usually it's a monthly fee. Some will do more of a little bit of a hybrid model where they'll actually charge per visit, but the majority of us do a kind of a time recurring fee. And that can, depending on where you're at, if you are, a rural area versus, Florida, your fees are going to be wildly different. I've seen anywhere from, for a middle-aged adult having a fee from $50 a month to $200 a month. And so mine is $130 a month, and that's for the Omaha area, that's kind of in line with where everyone else is at. So it's based on that. So in general, the general rule is that you're going to see about 1% of your patient base per day. So if you have 500 patients, you might see 5 people a day. Which, if again you do the math, that's about an hour a day, or hour per visit, versus 10 or 15 minutes with the conventional model. So it works. It's just a little bit different. There are days where you're going to be super busy. Where busy for me now is 7 to 10 patients, and that doesn't happen very often. My slow days are I don't see anyone. Sure. There are days where I do not see a single person. Now that doesn't mean I'm not doing anything. I'm doing a ton of other things, but but in conventional model, average is 20 patients a day for most primary care docs. So
at 15 minutes a patient.
At 15 minutes a patient. So yeah, it just makes it allows us to do all the things we need to do for someone and hopefully not miss things.
Sure. So then when we think about this, so just to make some math relatively simple, because I'm sure there's medical students, residents, other people out there who are looking at this and are like, I don't buy it. I don't get this whole direct primary care. How am I supposed to pay off my loans and so forth and so on doing this? So, and tell me if I'm really off on these numbers.
Okay.
But I've seen where the averages for, like a panel for your average primary care doctor, whether it's family medicine, internal medicine, might be somewhere between 4,000 and 5,000 patients. And then, and then for direct primary care, because they want to spend, because like yourself, you want to spend more time with your patients. Maybe you got 800 or 1,000 patients that are your patients. So you're seeing 1/4 as many people. But if, again, just to make the math easy, if your subscription fee is $100 a month and you got 1,000 patients, that's a substantial amount of money.
Right.
And even if your overhead is 50%, which it would never be in a direct primary care practice, right? I mean, between you and your employee, your wife, right? And then whatever supplies you need and the rent, it's not going to be anywhere near 50%.
No.
Right? I mean, to me, that math is way better than you working for the insurance company and supporting 17 or 18 other people.
Right. So to make it easy, so let's say even a relatively low number of 300 patients or 300 patients in my panel, $100 per month. That's $360,000 per year. That's gross income. That's not net. But again, if your overhead is 20%, something like that, which you can make it work that way for what we're doing. You're looking at upper 200,000s, and that's for most employed primary care physicians, 250 to 300,000 is a good average number these days. So, but again, you're seeing 3 to maybe 5 patients a day at that level, and versus 20. So you can make it work however you want. Obviously, the more that you see, the more patients in your panel. So 400, 500, 600, you're going to need help. And from what I've seen, most people who are in this space are seeing that they need extra help once they hit about 150, 200 patients. So they'll have virtual assistant or something like that, or they'll have actually someone in their office, an MA or an RN or something like that, around that number, where it becomes a little bit more tough. It becomes tougher to do everything yourself.
Sure.
At the beginning, you keep it simple, keep it inexpensive. There's a lot of ways to reduce your expenses and not go crazy with it. And I think from what I've seen in other practices, and again, everyone is different. Everyone has different starting points where they may have started out with a bigger nest egg to be able to spend on that, or they really saved for that, versus others that have from nothing. Let's say a resident that has been living paycheck to paycheck essentially. They may have to really kind of scrounge to figure out, okay, how am I going to get this going, and keep it going. So we can kind of get into that if you'd like. But.
Sure. Well, why don't we? So obviously you mentioned that there's a lot of business decisions that go into this. You're a business owner now.
Right.
You run a business.
Right.
Which obviously has a whole bunch of advantages, but then there's a whole bunch of responsibility. Right. And a lot of decisions that I think most of us in our medical training were never taught how to navigate. Right. So tell us about that piece. How did you navigate that?
So I didn't have any significant business background. I wish I did. I would have loved to have more business classes when I was in high school or college, but I wasn't foreseeing this to being part of my future, which again, whatever. You start where you can only start where you start. So, the decision to start up and go forward with it, obviously you have to have other people on board with you, right? So you're particularly your family. If you're married, if you've got kids, having them on board is huge. And that honestly, that was probably the biggest thing. My biggest impediment initially was that my wife Melissa, she was like, what are we doing? And why are we going to go from a fairly steady paycheck to not knowing exactly what is going to come in? But I told her I can't do it anymore. I'm just telling you, I can't do it anymore. So once we got into how we start this up. And I did a bunch of research on my own, and like everyone else does, I Google and I look things up. We love to hear that, don't we?
Sure.
I looked up my symptoms on
Dr.
WebMD.
Google told me.
Right. So I'm sure your accountants and your lawyers like, God, these guys are. But it's honestly, it's not that difficult. It's not that difficult to set up your own LLC and so forth. So once I explained to her, okay, here's what this looks like, and here are the advantages from a lifestyle perspective. Here are the maybe disadvantages from an income perspective. We can do just fine here. But if I'm going to continue doing what I'm doing in the conventional model, this isn't working very well. So I had to change. So so convincing her initially was it took a while. And I actually was starting up things while I was trying to convince her. But so that was kind of the initial phase. And then trying to figure out, okay, how. Obviously, you have to spend money to be able to start this thing up, and it's not that expensive, honestly. The expenses, I think I calculated at one point it was probably like $10,000 to $15,000 to kind of start up, and we haven't used any loans, we haven't used anything like that. So it's all savings and whatnot. So that has been really, really nice not to be able to have to be beholden to paying off loans. And now I still do have student loans from med school, which stinks, but we had that kind of figured into the equation. Sure. So it's a lot of prep work. The whole process for me. So it started in early 21, and by the end of so like January of 21, I started. That's when it started, and then we opened the doors December of 21. So about 10 months or so, 10, 11 months, and by really October of 21, I was pretty much ready for doors to be open. So that my biggest issue that I found was just trying to find a place, a physical space for us to have the clinic. I searched around a lot of different places. So really, what I wanted to do, I didn't want my own place. I didn't want I didn't want to build a clinic. I didn't want to, rent out a building in a strip mall, although that would be nice. What I was looking for initially was to keep the cost down was subleasing. So I looked at a bunch of specialists who were in the area that I wanted to be in, and started just calling them. I knew some of them already, and say, hey, do you have space? I just need one room and maybe a small space in an office. So I wasn't going to take up much room. They wouldn't have to deal with any of my patients, anything like that. So it took about, I think, my fourth or fifth try, and I eventually got in with a physical therapy clinic out in West Omaha, and they have been wonderful. They actually they had a back room that was like a kitchen that they really weren't using. So they actually renovated the whole space for us.
Oh, wow.
And so that was our office. And then they had an exam room that they really weren't using because that clinic was a little bit slower than some of their other ones. So, so I just have one exam room and then an office that has, a couple of desks and a refrigerator and a sink and just basics. So I have a little bit of a lab there and storage and whatnot. So, for me, it was nice to have that separated space between, the patient room versus in my office. I know there's others that have their basically office in the exam room and they only have one room, and that's totally fine. But I wanted something a little bit separate. So yeah, so that's kind of how it started up and how I got into it, and
that's awesome.
Yeah,
that's exciting. So, as you look back, so it's been 3 years now, going on 4 years?
Almost 3 years. Almost 3 years now.
Okay.
Yep.
So almost 3 years now that you've been doing this.
Yep.
In looking back, so every single one of us, I can give you a huge laundry list of the things I wish I had done differently when I started my practice, when I started building it. Mm-hmm. What are the lessons that you've learned in terms of building the direct primary care practice that you could do better now if you were giving somebody advice?
Yeah. So, number one, like I already mentioned this, but having a little bit more knowledge and education in just business, accounting, marketing. So marketing has been probably the piece that has been the most difficult, I would say. The bookkeeping and the accounting, all that stuff is not terribly difficult. It's just numbers. But marketing, and I think, and maybe this is maybe true for you, but I think for a lot of physicians, marketing themselves and talking themselves up is a very difficult thing. We're just not used to doing that. That's why a lot of physicians go employed, because they don't want to have to deal with that part of building a practice. They don't want to go out and try to sell themselves. It's hard. And I'll have to admit to myself, I haven't done the greatest job at that. I think that is probably the thing that I wish I did better at, and I'm still working on that. Where again, trying to go out there and again sell yourself, and which is one of the reasons why we're doing the free market medical association.
Right.
I think that has a huge opportunity for a lot of the direct primary care and direct specialty care operations, where trying to get those basically customers coming in a little bit more regularly. So yeah, the marketing piece is for me the biggest issue that I'm still working on.
Sure. So tell us about your thoughts on the Free Market Medical Association.
Yeah.
What's been your experience?
Well, the president is, no, I'm kidding. It's been a really neat ride so far. Obviously you introduced me to that earlier this year, and we went to Oklahoma City for their annual meeting, and I learned a ton of stuff about, kind of all the other spaces that FMMA is into. And obviously direct primary care is just one part of that. And,
sure.
Learning about how others, particularly the direct specialty cares, are approaching their part has been really fascinating to me, because honestly, I really hadn't even thought of that. I had spoken with a specialist here in Omaha. I think it was about 2 years ago or so. Real good guy, and I knew he wanted to kind of get out of the system, and I told him, hey, think about direct specialty here, direct care, the direct care model, and he just couldn't get past the well, what do I do with like all these procedures that I do. I'm like, well, that's a good question, and I didn't have an answer for him, because at that point I kind of knew about some of the the surgical centers and those types of things, but that now I think would be a better conversation with him. But I think the FMMA has been good at giving us some of the tools to be able to talk with the buyers and the sellers of healthcare, which again is kind of hard to wrap your mind around. Medicine being a buyer and seller of medical care. It's just a different way of thinking about it.
Sure. Although the irony is, in so many other countries, that's exactly the way it is, right? Mm-hmm. And that's the way it used to be here in the United States not that long ago.
Right. We've just collectively forgotten about it.
Right. Exactly. And what you've done largely is remember it. Recapture some of those concepts to make healthcare better.
Right.
So, as you think about, well, actually, let me change directions here. We'll change gears a little bit. So obviously, you would never bring up what I'm about to say for purposes of patient privacy.
Right.
Okay. But you are our family physician.
Right.
Okay. And I feel really strongly, and those that have listened to this podcast before know that I feel like if I'm going to talk the talk, I better walk the walk, right?
Right.
And if I really believe that direct primary care is the way to go, well, then our doctor is going to be a direct primary care doctor, which you are, right?
Yep.
And we're very proud of that. We're excited about that. But one of the things that I've found, I knew this here, but I didn't really know it here until my son broke his arm, And I really you may find this a little bit embarrassing, but I want to embarrass you a little bit this way, okay?
Go for it.
I was blown away, even though I knew direct primary care was great, and I'd heard all the stories. I was blown away by the reality and the experience. So my son breaks his arm. We could have gone to the ER. I looked, I was like, I think that's broken. Yeah. But I'm like, I'm not his doctor, I'm his dad. And I'm like, we can go to the ER, we can get some x-rays, and then we can end up getting referred to an orthopedic surgeon, and then we can get casts, and that'll end up costing us probably like around $10,000, between all that stuff.
Yeah.
I said, wait a minute. We have a direct primary care doctor. Yeah. And so we called you up. This was awesome. Yeah. So we called you up, and you're like, yeah, go ahead and get some x-rays. I'll put in the order. We get the x-rays done at a fraction of what it would have cost in the ER.
Right.
Like a really small fraction.
Right.
And then you said, oh yeah, go to such and such a place, get the splint. I looked at the x-rays already. I said, and you asked me if he was neurovascularly intact. I said, yeah, okay. All right, get the splint, put it on, and I'll see him. But I wanted to be stabilized.
Yeah.
Okay, so we did that. Again, at a fraction of what it would cost if we weren't paying cash.
Right.
And then x-rays, then a cast, then more x-rays, then another cast.
A home visit.
And that's exactly what I was going to get to. So at one point, so my wife was sick, and we didn't know how we were going to get my son to your office. Yeah. And you're like, you guys don't live that far away. I'll just come and do a house call. I was like, what? A house call in 2024. I know people that do that, but I was like, now I really know somebody that does that, and I was just blown away. And when we add up the cost of all that care, including the subscription, I think it was compared to $10,000, we ended up paying less than $400 out of pocket for all of that.
Yep.
For better care, for somebody who answered my calls right away, and correct me if I'm wrong, but it's not just because I'm another doctor.
That is correct.
Right? I've
done house calls for others too.
Yeah.
Absolutely.
And I love that.
Yeah, so do I.
I love that. Now, why don't primary care doctors in an insurance model do house calls anymore?
It's they don't know how to bill it. I think that's the biggest thing. I think they would do it. Actually, when I was in kind of the old system, I didn't make a house call per se, but I had a patient who could not get her medication, couldn't get she just couldn't physically get to the pharmacy, and I needed to see how she's doing anyway. So I went to the pharmacy. I actually picked it up for her, and they were like, "Excuse me, what?" And so that was kind of an odd thing. But then I went to her house and dropped it off, and just made sure that she was doing okay with her issues. And obviously I didn't charge for that because I don't think I should have. It was just really just how are you doing and just making sure we're okay. It wasn't really a in-depth visit, but if it was like an hour visit where I need, at that time at least, I probably would have had to found out how to bill some of that stuff, or I'd have just done it for free. I don't know. So it's initially when I started my DPC practice, I initially charged for home visit. I'm like, why am I doing this? I'm really not making any huge money on this, and it's I'm not doing it a lot, so it adds a layer of complication. I'm just gonna cover that for free. I'm not gonna charge extra for that. So I'll only charge a few things outside of the membership fee. So like labs and so we draw labs in our clinic, and those are really, those cash based labs are so less expensive than running it through the hospital lab on insurance. So that, and then just some medications that we would inject, like steroids or something like that.
Sure.
I don't charge for anything else. EKGs, urinalyses, that's all covered. So there are some direct primary cares that charge out those individual things. There are others that include all of it, including let's say a huge panel of labs
Sure.
that you can do once a year. And so, if someone is really looking to start up a DPC practice, they can do whatever the heck they want.
Sure.
If you want to do it that way, if you think it's simpler to just include everything, and that again, that's the beauty of doing this on your own, is that you can make those decisions. Whatever is best for you, you make that work.
Sure.
Right. So like for the cast, I didn't charge for that. It's pretty inexpensive material, and that should, in my estimation, should just be part of
subscription,
that care.
Yeah.
So
yeah, just like using the towel at the gym, right? They don't charge you to use the towel.
Hopefully not.
Yeah, hopefully not. Right. Maybe some gyms do.
my grandpa always said, put a quarter on the toilet.
Yeah, that's right. That's right. Exactly. So, as we finish up here in the last few minutes, I'm going to ask you the same question I ask every other physician who comes on.
Yeah.
And I think it's probably the one question that every single one of our listeners wants to hear. Mm-hmm. They want to hear the answer. They want to hear your take on this. Right. What would be your advice to the medical students, the residents, the fellows, the brand new attendings that are listening, who are curious about direct primary care? Mm-hmm. Well, what advice would you give them? What do you wish you had known?
Yeah, so this is, and I knew this, and this actually has nothing to do with DPC in general. And I knew this. And this was told to me when I was third year in residency. Live like you're a resident. Live like you're a resident. So, residents at that time we were making $50,000 a year, and you make it. You do fine. It's better than paying to go to school. But you have choices to make, and those choices weren't fancy cars. They weren't big houses. They weren't anything that you wanted. I think a lot of residents, once they are out and once they're starting to make a little bit more money in that system, and I think that's where a lot of them are looking at this as, well, I get this guaranteed income. Then they like, I can relax. I have a little bit more money now. I can spend it on whatever. So, and that's fine. Everyone has their own prerogative to do that. But if you want to either do something that is a little bit more risky, a little bit more rewarding, right? It is risky, but there is a reward. Start saving for it. Start living like you still don't have any money, and for a while you may not. You may have to do some moonlighting, and that's a whole separate topic. But still living like you're a resident and saving that money, because if you have a nest egg, if you have some money that is saved away, those decisions that you're making about your business are going to be different than if you are in debt, if you need to, pay for a fancy new clinic that you just bought because you took out a loan. You got a lot of stress on you to succeed. But if you keep the overhead low. If you and live like you're a resident, I think that the stress and the experience that you have starting up your business and watching it kind of slowly grow organically is a much more rewarding experience. So it's something that, it was told to me. Was I perfect at it? Absolutely not. I wish I was better at it. But that's where I'd say, if you really want to do this, look at your finances and really try to make it work in that regard.
Awesome. Yep. Awesome. Any other last thoughts? Any other last tidbits you want to share?
I talk to residents every year at Clarkson Family Medicine. They during their it's kind of business type of a rotation where they learn in business and medicine. And so they have me come in talking about direct primary care as an option, and every one of them is at least interested in it. They may not be doing it, but they're like, I really like it. I love the model. And to me, that gives me hope that, at least giving them the basic tools to work with is that's rewarding for me, but also knowing that there's another generation and some new docs coming out that are like, God, I really like this. I think I can make it work. Maybe I work in the system for a couple of years and kind of do some things, and I'm going to make it work when I can, and that's fine. Everyone's different. Everyone's situation is different. So I think that has given me a lot of hope that our system, yes, it is pretty broken, but it is hopeful that we can change it from the ground up, one doc at a time. This is not a huge movement. There's certainly a lot of us doing it, but it's only in the thousands right now. So there's I think the stat is like about 1 million physicians out there in the U.S., something like that, in total. So this is a drop in the bucket, but I think when people see kind of what this is about, they'll say, man, I like that. I wish it was like that. Okay, well then go out and do something about it, and right. and let's get going.
Yeah. All right. Well, thanks for joining us for today.
You're welcome.
Thank you all for joining us on the Direct Care Movement podcast. I'm your host, Dr. Demetrio J, Aguila III. We had the pleasure of having Dr. Brent Holmquist on with us today. Oh, I forgot to ask you one last question.
Yeah.
Are you taking new patients?
I am.
How
Absolutely.
do they find you?
So I have a couple things. Website is goodlifemedicinedpc.com. Facebook is Good Life Medicine DPC, and Instagram is the same.
Awesome. And then would you be open to medical students, residents, other physicians reaching out to you?
Absolutely.
And do they reach out to you the same way?
Yeah.
All right.
Absolutely.
Thank you for joining us on the Direct Care Movement podcast. We're excited that you joined us, and we're looking forward to having you join us in future episodes as we dive into more questions and more concerns and more solutions in the direct care space, whether it's direct primary care or direct specialty care. If you liked what you heard and you want to know more, please click like and subscribe and leave us a review. And don't be afraid to reach out to us directly so we can get you more information about direct care, whether it's direct primary care or direct specialty care.